Epilepsy is a condition which has been recorded in most of our ancient civilizations. Often called the divine madness or the falling sickness, it was regarded with wonder and fear. Caesar was a victim of this disease, as was Napoleon. It spares no race, no sex, no age, although more commonly occurring for the first time in childhood. Many of the ancient superstitions and misconceptions about epilepsy have persisted until the present time. Only recently, as history is measured, have we begun to replace ignorance and superstition with factual knowledge. One of the devices which has been helpful in our understanding of this disease is the electroencephalograph, which amplifies and records the electrical activity of the brain. Here we see electrodes being affixed to the scalp of a normal person. These small metal discs detect the changes in electrical activity that are occurring, transmit this change into the electroencephalograph itself, and in turn, these small changes in electrical activity are amplified many times until they finally can be displayed on a graph in a manner similar to the electrocardiogram. It is a safe, painless, and rapid method of evaluating many diseases of the brain. Experience over the years has taught us how to distinguish the normal electroencephalographic patterns, such as we see here, from those which demonstrate some type of disease process. Other illnesses may simulate epilepsy, and the electroencephalograph helps us arrive at a proper diagnosis. It also helps us understand the causes of epilepsy. However, the actual witnessing of a seizure is often more valuable than all scientific instruments. What we have just witnessed is the catastrophic onset of a generalized convulsion with its associated vigorous, generalized muscle movements of a tonic and clonic variety, and the associated deep loss of consciousness followed by the profound coma of the postictal state. This electroencephalogram demonstrates that there is a parallel profound change in the electrographic pattern of the epileptic. When the word epilepsy is heard, one usually conjures up a visual image of a generalized convulsion. However, there are many forms and types of epilepsy, and some are manifested only by minor disturbances of consciousness, such as we see in this young child. These are merely ripples in the stream of consciousness, akin to the ripples we see in the brook when we toss in a small pebble. They last only a few seconds and may be associated with minor blinkings of the eye, staring, or arrest of activity. Such seizures most commonly have their onset during childhood and may often go unrecognized as a form of epilepsy, or may even be totally unwitnessed unless the child is under close, direct observation. In this child, for instance, one has to watch closely to see the brief little staring spells or interruptions of activity. As we watch her, we see that they repeat frequently during this brief time, and in some youngsters, such brief disturbances of consciousness may occur dozens of times per day. Sometimes this is the only manifestation of epilepsy in children, but in some there may be both minor episodes as well as the more generalized convulsions. There is a profound change in the electroencephalogram in association with this type of seizure, and it is often categorized as 3 per second spike wave activity. This type of epilepsy is often called Petit mal. Petit mal seizures may vary considerably from patient to patient and are often difficult to distinguish from other forms of epilepsy arising from different types of disturbances. Certain so-called activating techniques are helpful in bringing on a seizure so that it can be witnessed. We have asked this lady to hyperventilate or breathe rapidly. As you will see, it does bring on a seizure of the Petit mal variety, but somewhat different from that which occurred in the child.
Did you have a seizure then, Kathleen?
A light one.
What happened? How did you feel?
Hit the chair with my right arm, hand.
What else did you do?
Funny sensation through here.
Did you see me walking around here?
Yes.
Remember what I did?
No. I just saw you walk over there toward the camera. And then I saw you look toward Mr. Jackson. That was it.
You feel all right now?
Yes, sir.
Here we see the spike wave pattern that occurs in the electroencephalogram in association with Petit mal seizures. There is some controversy as to what is or is not Petit mal, as the term itself only implies some type of minor seizure. Traditionally, the term Petit mal has been reserved for those brief, minor episodes that are associated with the fairly typical EEG pattern that arises and ends abruptly out of a normal background and lasts only a few seconds. However, Petit mal does vary and may be associated with certain automatic or repetitive movements, similar to those we see in other types of epilepsy. Here is another variety of so-called Petit mal associated with a spike wave pattern. The manifestations of this type of epilepsy differ with the maturation of the brain, becoming somewhat more prolonged and more complex clinically and electrographically. This change may reflect the evolution from minor towards major seizures associated with maturation of certain brain regions. Occasionally, such episodes may become quite prolonged and are often called Petit mal status.
Marilyn? Marilyn, take your hand down. Put your hand down. Are you all right? Just sit back and relax now. What is your name? Tell me your name.
Kennedy.
What's your first name?
Marilyn.
Not all minor seizures are petit mal. Rapid, brief muscle contractions occurring in all or a part of the musculature are called myoclonic seizures. These may arise as isolated phenomena or may be associated with other forms of epilepsy. Some authorities feel that they represent a variant of the petit mal type of epilepsy, and others feel that they are simply partial, incomplete, generalized seizures. In this patient, we're using a different type of activation procedure to bring out the seizures, namely photic stimulation.
Keep looking at the light. Look right at the light.
Epileptic seizures can be evoked by a variety of external and internal stimuli. Different forms of visual stimuli, ranging from this flashing light to the sun glinting off the snow or sand to certain patterns seen in clothing or on television screens, may produce convulsions. In some people, it may activate the electroencephalogram, producing a seizure pattern without clinical manifestations, or, as in this patient, it may provoke seizures so that they can be witnessed and correlated with the accompanying electroencephalographic changes. The phenomenon of myoclonus is not completely understood, and there are some forms of movements of this type which need not necessarily be connected in any way with epilepsy. There is another large group of minor or partial seizures which have been termed psychomotor or temporal lobe seizures. As the name would imply, there is a disturbance of psychic as well as motor function, and at times of many other functions. Some of the simpler, less complex forms of this type of seizure may be difficult to distinguish from the more prolonged varieties of Petit, and one may see seemingly purposeless, stereotyped automatic activity such as this woman demonstrates. Fumbling with the clothing is a common component of this type of seizure. These seizures tend to be somewhat more prolonged, and the activities and movements are more complex and at times have a more purposeful pattern to them. These patients do not lose consciousness, but are obviously not totally in contact with their environment. Although it may be difficult clinically to distinguish between this type of seizure and Petit, the distinction is an important one to make, as different types of medicines are used in their treatment. Temporal lobe seizures may be associated with progressive disease processes, such as neoplasms requiring surgical treatment. The electroencephalogram can be of value in making the proper diagnosis, for it may show evidence of focal involvement rather than of the more generalized involvement which we have seen previously. The electrical activity derived from the temporal regions of the brain may be abnormal, the abnormalities varying with the nature of the underlying disease process. In this lady, with a focal spike wave form, we would presume the disease to be of a chronic or static nature, for example, an area of atrophy or scar formation. This patient also is having a psychomotor or temporal lobe seizure. As you can see, hers is somewhat more complex, and her movements seem to have a greater purpose, even though they are apparently irrelevant to the situation she is in. Although this part of the film is silent, you can see that she is talking and vocalizing, apparently in response to some stimulus which is separate from her immediate surrounding environment. If she were not restrained, she might well get up and walk about the room, and her behavior might seem rather bizarre and unusual. On occasion, such seizures have been misinterpreted and considered to represent some type of psychotic or otherwise emotionally disturbed behavior. With seizures of this type, patients often have a warning or aura. There are myriad forms of these warnings, ranging from simple subjective feelings of uneasiness or dizziness to complex hallucinations. These hallucinations may be of the olfactory, gustatory, auditory, or visual type. Epigastric distress or feelings of choking or constriction of the throat may form the aura. There may well be distortions of the environment or changes in mood and affect, or even autonomic changes such as acceleration of the heart rate, borborygmi, or urges to defecate or micturate. The warning itself is in reality a part of the seizure, often representing the initial event, and the nature of it tells us, at times, what area of brain or what area of the temporal lobe and its associated systems is involved. As a sequel to, or in response to these complex warnings, the patient may at times become highly overactive, belligerent, fearful, withdrawn, or disturbed in some other fashion. The seizure may terminate after a varying period of time and may be followed by some degree of amnesia and confusion. The patient may or may not recall the varying events that took place. If the spark that initiates this type of seizure spreads to adjacent or deeper structures, other seizure phenomena may occur, such as we have seen in this woman, with postural upraising of extremities, adversive movements of the eyes, and ultimately the culmination in a generalized convulsion.
Mary? Mary? How do you feel?
I feel pretty good.
What happened to you? What happened?
I felt pretty bad.
How did you feel bad?
I felt like I was going to have a spell.
Did you have a spell?
Kind of a little.
How did you feel? What sort of a feeling was it?
Well, start feeling bad.
Where did you feel bad?
In my neck.
In your neck. Anywhere else?
No, sir.
What kind of a feeling in your neck did you have?
I'm just going to feel like I'll feel dizzy.
Did your neck hurt?
Yeah.
Do you know where you are now?
Yes.
Where? Where are you, Mary? Where are you now? What's the name of this place?
The name of it is Horton Building.
What are they doing here?
They're testing.
Do you feel all right now?
A little.
Do you have any headache?
Just a little.
Does your stomach feel all right?
No.
What's wrong with it?
Just a little less.
Can you tell me your name?
No, ma'am.
How old are you?
26.
All right.
Presumably, any gray aggregate in the brain may act as an epileptogenic focus. Thus, a variety of partial or focal seizures are possible. For example, focal motor or Jacksonian seizures, in which there is only limited involvement of certain muscle groups of the face or extremities on one side of the body. This is an adversive seizure, with head and eyes turning to one side, and then, as is possible in any type of seizure, further extension of the abnormal activity to all parts of the brain, resulting in a generalized convulsion. Following a seizure, the patient is usually amnesic and commonly sleeps for a period of time. In the postictal or post-seizure period, the patient may, however, demonstrate automatic, seemingly purposeless movements arising out of his confusion and disturbed awareness. Thus, we may have post-ictal automatisms as well as petit mal and temporal lobe automatisms. Of course, the sequence of events helps us make the distinction between these types, and the electroencephalogram following a seizure usually has a characteristic pattern which can be distinguished from other types of seizure activity. We have been able to show a small number of the vast and varied seizure types. Many physicians, nurses, and paramedical personnel have never seen a seizure. Hopefully, this film will alert professional people to the possibility of epilepsy in any patient with episodic, recurring disturbances of awareness and behavior. When epilepsy is recognized and properly treated, about 75 to 80% of the patients can be kept nearly or totally seizure-free. Under proper care, epileptics can often lead a normal, productive, and happy life. Thus, although we have no cure, epilepsy is a hopeful condition.